The focus of this lecture is to evaluate the cranial nerves, the motor system with all its components, the sensory system, and the reflexes. You all know as nurses that the nervous system anatomy and physiology is very complex, and neuroassessment's challenging, but it is obtainable with practice and dedication. The nervous system really affects all body systems, so knowledge of the neural function plays a role in the evaluation of any illness. There are 4 guiding questions for the examination of the nervous system. They include, does the patient have a neurological disease? If so, what is the localization of the lesion or lesions? Are your findings symmetric? And what is the pathophysiology of abnormal findings? And the 4th question is, what is the preliminary differential diagnoses? So you have to be familiar and knowledgeable of the anatomy. So let's just do a quick review. The brain. It has 4 regions, the cerebrum, the diencephalon, the brainstem, and the cerebellum. It contains interconnecting neurons called bodies and axons. Our gray matter in the brain is aggregation of neuronal cell bodies, and the white matter is neuronal axons coated with myelin. The spinal cord extends from the brainstem, the medulla, to the lumbar 1 and 2 vertebrae. It contains motor and sensory pathways that exit and enter the cord via the anterior and posterior nerve roots and the spinal and peripheral nerves. You know that the spinal cord has 5 segments. Cervical is C1 through 8, thoracic T1 through 12, lumbar L1 through 5, your sacral vertebrae S1 through 5, and your coccygeal. The peripheral nervous system is really the cranial nerves. There's 12 pairs of them, plus the spinal and peripheral nerves. The cranial nerves govern motor, sensory, and specialized functions like smell, vision, and hearing. There's 31 pairs of peripheral nerves that attach to the spinal cord, 8 cervical, 2 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. Each nerve has an anterior or a ventral root containing motor fibers and a posterior root containing sensory fibers. The anterior and posterior roots merge to form a short, really less than 5 millimeter spinal nerve. Spinal nerve fibers commingle with similar fibers from other levels to form the peripheral nerves. So within the peripheral nervous system, there's motor and sensory pathways and dermatomes. So the motor and sensory pathways are the descending and ascending sensory pathways. And the dermatomes are actually bands of skin that's innervated by the sensory root of a single spinal nerve. They're very telling and help you locate where the pathology could lie, depending on where the symptoms are apparent or assessed. So common and concerning symptoms of the nervous system include headache, dizziness or vertigo, generalized proximal or distal weakness, numbness, abnormal or loss of sensation, loss of consciousness, syncope or near syncope, seizures, tremors, or involuntary movements. All of these bring a level of concern. The primary focus within the nervous system with health promotion and counseling really is to prevent stroke or a transient ischemic attack, a TIA. We also are always trying to reduce the risk of peripheral neuropathy, and we want to hone in to detect the 3 Ds, delirium, dementia, and depression. I think it's also important to remember as you examine your patient to ask yourself or evaluate if the mental status is intact. Are their right or left-sided findings the same, or are they asymmetric or symmetric? If the findings are asymmetric or otherwise abnormal, do the causative lesions lie in the central nervous system or the peripheral nervous system? And you'll need to know the difference in order to evaluate that. you got to organize your thinking into 5 categories. And I think if you do this in a systematic way, you will really increase your competence in a neurological evaluation. You will consider mental status, speech and language, the cranial nerves, the motor system, the sensory system, and the reflexes. So let's just examine or review for just a moment the 12 cranial nerves. Cranial nerve 1 is the olfactory, number 2 is optic, number 2 and 3, which are linked together, is the optic and the oculomotor. Cranial nerve 3, 4, and 5, oculomotor, trochlear, and abducens. And cranial nerve number 5 is trigeminal nerve. Cranial nerve number 7 is the facial nerve. Number 8 is the acoustic. 9 and 10 is the glossopharyngeal and the vagus. Number 11 is the spinal accessory. And number 12 is the hypoglossal. Okay, and I just want to clarify that cranial nerve number 6 is the abducens, and it has to do with lateral deviation of the eye. You can note that on the right side of these charts, the effect and the utility of that nerve is highlighted. Please know that you need this for the rest of your practice. When you're examining the motor system, I want you to keep in mind that the motor pathways are complex avenues that extend from the upper motor neurons through the long white matter tracts to the synapse with the lower motor neurons and continue to the periphery through the peripheral nerve structures. So let's look at an examination. We're looking at position, movement, muscle bulk, and tone. We're going to observe body position, involuntary movements such as tremors, tics, or fasciculation. Inspect the muscle bulk. Note any atrophy, and whether that's bilateral or unilateral. And also assess muscle tone. Flex and extend the arm and the lower leg for residual tension. Slight resistance to a passive stretch. Examination of muscle strength is graded on a scale of 0 to 5. So 0 being no muscular contraction, and then 5 being active movement against full resistance without evident fatigue. That's normal muscle strength. You always ask the patient to move actively against your opposing resistance. Sign of 5 if the patient overcomes your opposing movement. If the patient can only move against gravity, assign a grade 3. The typical examination for muscle strength would include testing for the muscle groups and movements, the biceps, triceps, and wrist, the hand grip and finger, and the thumb opposition, trunk, thorax, hip, knee, and ankle. It's also equally important to examine coordination. We do that through rapid alternating movements, point-to-point movements, and gait. And just review these particular assessment procedures. So this question wants you to answer coordination of muscle movement requires that 4 areas of the nervous system function in an integrated way. Coordinating eye, head, and body movement applies to which area of the nervous system? Is it the motor system, cerebellar, the vestibular, or the sensory? So the answer is the vestibular system. That balance and coordinating eye, head, and body movements. Look at this review. Motor system is muscle strength. The cerebellar system is rhythmic movement and steady posture. And sensory system is position. So further coordination examination might include stance, which is through the Romberg test. And you can review the Romberg. I think we're all familiar with that. The pronator drift is an interesting test of coordination where that patient stands for 20 to 30 seconds with both arms straight forward, palms up, and eyes closed. You tap the arms briskly downward, and if they pronate and a downward drift in the arm is apparent, then the test is positive. So let's review what it looks like to examine the sensory system, general principles. So you always want to compare symmetric areas on both sides of the body. When testing pain, temperature, or touch, you compare distal with proximal areas of the extremities, and you map out the boundaries of any area of sensory loss or hypersensitivity. When you're testing for pain, you use you compare two sensations, and you can do the sharp, dull. You have to test for light touch using a cotton wisp. You can test for vibration using a 120 hertz tuning fork, and the explanation is on the slide. And then we do test for proprioception, usually with the big toe. You're holding it up or down and see if they can identify that movement. Remember, this is within the sensory system. It's important to be able to assess discriminative sensation, and there's a number of tests to do that I believe are all familiar with. But stereognosis is where you take a key or a familiar object. The patient has their eyes closed and you ask them to identify it. Number identification, you have them close their eyes, draw the number in the palm of their hand. 2-point discrimination is usually done with a paperclip. And point localization, light touch on a point on the patient's skin and ask the patient to point to that spot. And extinction, touch an area on both sides of the body at the same time and ask if the patient feels one spot or two. Examination of deep tendon reflexes. Some of the general principles are definitely use a properly weighted hammer. Encourage the patient to relax and position the limbs properly and symmetrically. Hold the reflex hammer loosely between your thumb and index finger so that it swings freely in an arc. And strike the tendon with a brisk, direct movement. Use minimum force needed to obtain a response. And use reinforcement when needed and grade that response. Examination of reflexes are graded in a 0 to 4 scale, 0 being no response, 4 being a very brisk, hyperactive with clonus response. Again, the author of our book wants to reinforce what we understand about assessing reflexes and ask us regarding reinforcement when assessing reflexes is true, which one? Used when reflexes are symmetrically hyperactive, A. B. Technique involves isometric contraction of other muscles. C. Supports the unsteady patient. Or D. All of the above. So the answer is technique involves isometric contraction of other muscles. That's the reinforcement technique when examining reflexes. And it's used when reflexes are systematically diminished or absent. I'm sorry, symmetrically diminished or absent. I think this slide is so important. We go through and you're going to be learning the deep tendon reflexes, but I want you to keep in mind that they localize abnormalities. So look at that bicep reflex, C5 and 6, triceps, C6 and 7, supinator or brachioradialis, you're looking at abnormalities of C5 and 6, knee reflex is L2 through 4, ankle primarily S1, and then clonus would be a hyperactive response required for assigning a reflex grade of 4. It's usually elicited at the ankle. There are 3 cutaneous stimulation reflexes, so on the skin, with cord levels for a response to localized abnormalities. Look at these, the abdominal reflexes, the upper T8 and 10, and the lower T10 through 12, if they're positive. Plantar responses, L5 and S1, and then the anal reflexes, S2 and S4. These are very useful when trying to localize abnormalities. So finally, examination special techniques. I want you to review the asterisks and the assessment of the stuporous or the comatose patient. That's on the next slide. But remember the meningeal signs. Any sign that would imply that the meninges is inflamed. The Brudinsky sign and the Kernig sign. The Brudinsky sign is where the severe neck stiffness causes the patient's hips and knees to flex when the neck is flexed. And the Koenig sign is when you